Good afternoon, everyone. Let's begin. I'm Laurel Steimanoff, Executive Director for Quality Innovation at the Urgent Care Association, and I would like to welcome you to our fourth in a series of COVID-19 town halls. Our facilitator today is to be Dr. Sean McNeely. He was unfortunately called away briefly, but we expect to get him back at some point in the presentation. He's an Urgent Care Fellow, former UCA board member, and president of the board, as well as immediate past president of the College of Urgent Care Medicine. We're also joined by Dr. Joe Toscano. He's UCA's content coordinator for clinical education, a former UCA director, and current director of the College of Urgent Care Medicine. This presentation will be kicked off today by Dr. Jeff Morris. He is with the Studer Group, and we also have an impressive group of panelists and your peers in urgent care medicine to discuss the timely subject of provider burnout, keys to resilience during times of crisis and high stress. We've heard a lot about the challenges for today's environment, and understanding the stressors facing frontline workers is critical. We hope to provide some insight on what research says, as well as what your peers have found to work and even not work. A few housekeeping items before we begin. There are two ways to ask questions depending on how you are accessing this webinar. For today, it's an interactive session, so please put your question into the questions section on the Zoom menu on the bottom of your screen, and we'll answer them either as we go or at the end. If you're watching the recording, you can use the question feature in the UCA 2020 app. To submit questions, we'll share them with the experts and get back to you with the answers. At the end of our session, we have a short evaluation. Would appreciate your feedback so we can continue to improve. With that, I would like to introduce Dr. Morris of the Studer Group. Dr. Jeff Morris lives and practices in Ohio, though he is originally from South Africa. I think you'll hear that when he starts to speak. He completed residencies in South Africa, Israel, and Canada. After attaining board certification, he practiced orthopedic and hand surgery in Thunder Bay and then in Burlington, Ontario, before moving to the USA in 1990. In 2000, Jeff graduated with an MBA from Kent State University. He served 12 years as the Regional Vice President of Medical Affairs at 2 local community hospitals, and subsequently joined the larger Summa Health System in Northeast Ohio. During his tenure as a physician executive, these community hospitals engaged the Studer Group to elevate the culture of services and enhance communication to new heights, giving them a significant competitive advantage over other facilities in the area. In May 2010, he became a part-time physician coach with the Studer Group while serving concurrently his positions with the community hospital system. In 2012, he left his administrative position and transitioned full-time as a physician coach with the Studer Group. He helped create the Healthcare MBA program at Kent State University, where he taught healthcare marketing. He has co-authored a number of books, including on medical evidence, the CG CAPS Handbook, and the OAS CAPS Compendium. He is certified as a medical acupuncturist and maintains a small clinical practice now in non-surgical orthopedics and medical acupuncture. With 36 years of medical practice, 12 years of physician executive leadership, and more than 10 years as a Studer Group coach, speaker, and author, he appreciates the real connection between enhanced physician compassion and communication with improved clinical outcomes. With that, I'm going to turn it over right now we're pleased to present it, Dr. Jeff Morris.
Well, thank you very much for the opportunity. I greatly appreciate it, and truly I'm looking forward to this discussion. We've met with a panel one time earlier, and I'm so impressed by hearing some of the things that are being done to deal with burnout and to build resilience amongst the urgent care team. So it truly is a pleasure to be here. Can we go to the next slide? And you can advance it again. We really know today that there is burnout everywhere, and I think the prevalence is not to be denied, not just amongst providers, but amongst everybody in the healthcare system. A study that was done in 2018 showed that approximately 83% of respondents, that included clinicians and clinical leaders as well as executives in healthcare, considered burnout to be a problem, either moderate or serious problem at their institution. And so the question then is, why are we so burned out? Next slide. Well, there are a lot of well-meaning responses to this. If you ask people why are providers burned out, they'll tell you that, we don't learn resiliency, we don't learn to cope, we need to get more sleep and more exercise and learn meditation and mindfulness. And do more hot yoga and eat cold yogurt and everything would be fine. But the reality is the underlying message of all that advance is that you are the problem. The underlying message is it's you, not the system, it's you. And you need to do something about it. And that's clearly the impression that a lot of people have, and puts a lot on the providers to try to build their own resilience and get out of the state they're in, where the circumstances around them really don't allow that. Next slide. So who is really to blame? When you think about some of the things that we have to deal with, and they're listed, I'm not going to read them all, but just think about where we are in healthcare, in the urgent care world now. You've got fast turnaround, and you've got to worry about patient experience, and you're expected to do more with less and do it faster. And patients have enormous expectations about the kind of care and caring they should get. They feel they know quality because they read Google and WebMD. And at the same time, you're dealing with workload factors in which you really have too little time to do all the things that you need to and want to do and that you're good at. And you spend a lot of time doing things that somebody else could do, which is very frustrating and doesn't help our resilience. And of course, the loss of control and all the other changes that occur about us. So next slide is, why does this really matter anyway? We are concerned about it, and we have to think about why we're concerned about it. But let me just stress, and that's a good choice of words, that burnout and stress are not the same thing. In fact, stress, we thrive on it. We thrive on complex medical decision-making, thinking through things, taking the information we have at hand and finding an answer to it. That's our day-to-day job. We thrive on that. But that kind of stress, when we have time to decompress, it drains us, but we can recover. Burnout is when we get to the point that we're unable to recover. There's a cumulative effect both on our emotions as well as on our bodies. And actually, there have been neurologic effects that have been shown from cumulative stress. Next slide. So I'm not going to read through why this matters, and you can just think about this in a number of frames. There are the personal aspects of it, things that happen with depression, substance abuse, insomnia, erosion of relationships. There's the professional side where we become less engaged and our productivity goes down, quality can be affected. But it also affects the organizations that we work in and for, with reduction in employee engagement and increased turnover, which also goes with increased cost and usually with increased liability. And then, of course, we're all there for the patients, and they're the ones who are at the end get the decreased quality and poorer experience. And there is an issue of quality, as you'll see on the next slide, which you can advance twice. This is a very interesting meta-analysis of 82 studies and almost 250,000 healthcare providers all over the world. And it's pretty clear that burnout amongst healthcare providers is associated with poor quality and reduced safety for the patients. Now, there's arguments about whether that's just on the basis of the provider or the organization, but it's probably a combination of both. Well, with that background, why do we find it so hard to recognize burnout? And that will be the next slide. In fact, you can advance it 2 slides. Well, it's actually not a mystery why it's so difficult to recognize, why we don't see it in order to do something with it. The reason is, firstly, the signs are very nonspecific. You know, depression, insomnia, we don't really know necessarily who's got problems with substance abuse or issues at home. So sometimes there's very nonspecific, and usually there's very nonspecific signs. But even though they're not always obvious, the reason that they're not always obvious is because we are so well trained to hide the symptoms. We're expected to be superheroes and perfectionists, and we don't like to admit there's a chink in the armor. When things aren't going well, we put on that stoic face and we keep going forward and nobody knows what's going on. And so we really may know that deep down we have issues and concerns about burnout, but we certainly don't admit it to ourselves, and we certainly don't recognize it in others. The sad thing, as you'll see on the next slide, is that unfortunately our patients sometimes recognize it even when we don't. We'll go to the next slide. So how do we start to think about healing this provider burnout? How are we going to solve this problem? I'd like to think about it in the framework of organizational responsibility and personal responsibility. On the next slide, you'll see organizational responsibility. And I think we have to ask ourselves what can be done, because providers have a responsibility, as does the organization. And if you advance it one more, you'll see, in fact, advance it two more, you'll see what I think is a very interesting article from New England Journal of Medicine Catalyst back in 2017. And Christine Olson talked about provider well-being. In this case, it was about physician well-being, truly being a virtuous cycle where you want to have a culture of wellness and efficiency of practice and personal resilience. And each one of those affects the other one. Now, the organization can be primarily responsible for the culture of wellness and the efficiency of practice. The person obviously has to own their own personal resilience to some extent, but it is a virtuous cycle where one affects the other. When it comes to things that the organization can do to enhance the culture of wellness and efficiency of practice, it doesn't always cost money, and it doesn't always mean that you have to have a very expensive wellness program. Some of the things that I've seen done across the organizations, and you've got your panelists who are really knowledgeable and have done some things in their own organizations that they'll share with you. You remember we said one of the things is you spend too much time doing things that somebody else could do and doesn't help you do what you do best and what only you can do. And so how do we mitigate that? Organizations have included flow techs, scribes, increased clerical things. Those are people that can help you become more efficient in your practice. And there's often cost benefit issues there, but usually we find in the long term, because the cost of provider burnout is so high, when we lose providers or providers burn out and we have to change providers, there's a huge cost to that too. And so we have to start thinking upfront about what the cost benefit is of having support to do the kind of things that would take the burden off the providers and allow providers to be truly engaged in what they do best. One of the other things that we hear about are wellness programs, and wellness programs are fine, but not everybody necessarily needs to work out. And when I was a CMO and a number of the organizations I've worked with, we went to the people and said to them, what is it that you find stressful? What is it that's difficult for you? And we found there were simple things like working moms and dads who didn't want to go through a drive-through at night and take fast food home to their kids. And so what they did, for example, was we arranged a catering company to take orders in the morning and have home-cooked meals ready in the afternoon for them to pick up. It was nutritious meals, it was positive, cost us nothing as an organization. So those kind of things become very easy if you really find out what matters, what's barrier for these people. Value their time and where you arrange meetings. And we could talk more about what organizations can do perhaps during the Q&A. The next slide will talk about the individual responsibility. Can we advance? And advance again. And advance one more. So what can we do ourselves? And I think there's a lot of providers who point fingers and sort of say, well, the problem is them, the problem is the organization. And I do think there's a lot of organizational things that can be made better and more supportive for us. But we need to ask ourselves this question, which Dr. Wayne Sotil and Gary Simmons, Dr. Steele is a clinical psychologist who deals a lot with resilience. And Gary Simmons, can you go back? Talk about, now go back again. One more. Yeah. They talk about what, if the problem is 90% everybody else, what 10% are you willing to own? What can you do yourself to improve your ability to handle the pressures and stress? And that comes down to a number of things that we'll talk about in the next two slides. The next slide will talk about self-awareness and emotional intelligence, the ability to recognize what burnout you feel and to develop your own capabilities. And a lot of that requires personal insight and EQ. And truly what we have found is that those people with higher EQ, people who have greater insight into themselves, tend to be less burnt out. Doesn't mean they can't be burnt out, but they tend to be less burnt out. There's a very excellent article referenced here from Harvard Business Review. The next slide talks about what we call the ear. And the first is energy. Energy. Everyone will say the secret is having a balanced life. Balanced life of work and life. It doesn't happen. No matter how hard we try, we don't really get a balanced life. And there are three vital variables that determine who thrives and who doesn't. And Dr. Satil wrote this other book, Not Only Thriving in Healthcare, but Thriving Physician. And he talks about energy. What is it in energy that we need to manage? Physical, mental, emotional energy. We have a bank account. And we have to think about, are we making deposits or are we making withdrawals? If we are constantly making withdrawals, we have an empty bank account with no resilience. We have to fill our lives with things that are meaningful to us. We have to fill our lives with things that make us feel good, because then when there is a withdrawal, there's something left in that bank. And for providers, one of the greatest sources of that energy is the satisfaction that we feel when we treat patients and we get good outcomes. There's obviously other things that we can do, including just things at home, family, volunteerism, but doing good things makes us feel better. We've got to fill that account, otherwise it's just going to be drained. The A on ear is for attitude. And the question here is, what am I thinking? You know, we've got to take things that we see every day, familiar things, and start to see them in unfamiliar ways. Quite apart from medicine, think about it this way. You're standing washing dishes. You can have an attitude of, why the heck am I washing these dishes? I'm just going to put them away. They're going to get dirty again tomorrow. Or you can have an attitude of, I'm washing these dishes because it keeps my family healthy and it protects them. So we have to find meaning in what we are doing, and that will help us have the right attitude towards what we're doing. We've got to see past the old ways of doing things. We have to recognize that, yes, there are barriers, but we don't just paint over the rust. We recognize the rust and we deal with it, but our attitude of one is, how do we make this better despite the rust? And the third element and a vital variable is relationships. And please do not underestimate this important aspect. So many of our providers today have eroded relationships, not just with family, but with their peers. Some of them just don't ever see other providers. In the old days when everyone had a camaraderie around the hospital and hallway consults, things were different. We tend to be much more isolated, and we tend to ignore our relationships, even professional and at home. And also, when we think about things that way, we've got to start to say, what can we do to enhance our relationships? What daily uplifts can we find? Maybe going to somebody and say to somebody, what's one thing I can do today to make your life better? Don't be surprised at how positive that impact can be. And so truly, in the next slide, we will see that truly caring more, keep advancing, as outlined in the book Compassionomics, caring more, not less, leaning in more can actually be the antidote to burnout. And you'll see some really interesting studies on the next slide, because the classical teaching is that when you're burnt out, you should lean out, you should go do a nature walk, take time off, don't get too involved. But the systematic review of the literature currently shows the opposite. There is, in fact, an inverse association between compassion and burnout. Now, we don't know the causality. Is one the chicken and one the egg? We don't know, but the association is there. And so when you have meaningful relationships with your patients, you feel good about what you do, you lean in and you care more, you're less likely to be burnt out than if you lean out, stop caring, and it becomes a job for you instead of a calling. This is not new. In the next slide, you'll see there's an article that goes back to 1925, talking about the secret of well-being for those taking care of patients, and it's truly about caring. And so let me leave you before we go on to our esteemed panelists here who've got really great examples. Truly working hard is not the issue. People work very hard doing things they love and they don't burn out. They may take time. They will not have a work-life balance. That's a myth. They work hard, but if they believe in what they do, if they're connected with what they do, if they feel it's purposeful, that it makes a difference, and they feel worthwhile, then they won't burn out nearly as much. It's not just a matter of hard work. And with that, I'm going to turn it back to you so that we can turn to our panelists.
Great. Well, I took these in alphabetical order, so we'll start with Dr. Barlow. If you could just maybe do a little bit of introduction and then tell us what you're doing.
All right, thanks, Lola. It's great to be joining the UCA. I'm talking about this. It's obviously very, very timely, and that was a great discussion that Dr. Morris just gave us. Some things that we've incorporated at American Family Care, and we hope to do better going forward. But American Family Care has 240 clinics, so we have a lot of providers and a lot of staff that face this issue. And I trained in emergency medicine. I think from day one in my residency, we really started talking about this issue. And from early in my career, really started watching the leaders and how they dealt with this through my residency program, and then after when I was in the military, and how they addressed their people. And what I found was when my leaders communicated with me more and trained me based on the deficiencies and the frustrations I was having and training the staff, that things got better and we felt better as an organization and the providers felt better. And so, during this time of COVID-19 and the ups and downs that we've been facing, really what we've done at American Family Care and my team has really tried to increase our communication and increase our training. And so a lot of that went when we had a dramatic decrease in volume. We had a 60% decrease in volume at the beginning. We faced PPE shortages. We faced a lot of issues that really we had to increase our communication with our providers. It meant emails, it meant weekly calls, it meant site visits where my team or myself or the president of this company were going around to the sites and talking with providers and talking with staff, and then seeing what they were facing and then training the staff and the providers how to deal with the changes in flow. This especially came to effect when our volumes ramped up dramatically. We had a short period of volumes down, but then all of a sudden it really went dramatic, where I think our providers are feeling like it's the never-ending flu season. And so what we're working on now, and I think what addresses this is that efficiency of practice that he was talking about. It's making the clinics as efficient as possible for the providers. For me, what I think one of the big wins was really working with our electronic medical record company to decrease the number of clicks that our providers had to do to see COVID patients. Just 1 or 2 clicks on every patient can add up over the course of a day for these providers, and that efficiency was something that I'm proud of that we're doing. And then it was the communications, just talking about everything, whether it's the information coming about COVID from the CDC, the research coming out, the different treatments, and really getting all that information together and pushing it out into providers so that we could all be together as one team and not operate as islands as we face this pandemic. So those are the main things I want to mention. I think we're doing a lot of different things, to address this, and there's a lot of work still to do. But for us, it's really been about increasing communication and training.
Thank you, Dr. Barlow. Next, we'll move to Dr. Chow with Team Health, and we actually have some slides from Dr. Chow.
Thanks, Laurel. Thanks, everybody. I'm Joe Chow. I'm the group president for Team Health Ambulatory Care. We have 28 centers, mostly on the eastern side of the United States. Team Health as a whole, though, has 16,000 clinicians by and large, emergency medicine, hospital medicine, anesthesiology, so a whole cadre of providers. And so as a bigger group, certainly COVID and burnout has become a very big topic, certainly. Few things that I'll break this down into. Exactly what Dr. Barlow said. Communication and taking some of the stressors away from our clinicians as the stressors are coming. So for example, when COVID first came out, I don't think everybody really had all the updated information about COVID. I think most of us went to CDC websites or other websites. Team Health, we actually formed something called the Emerging Infectious Disease Task Force, where all the clinicians in this, we had clinicians from the heart in New York City of where the pandemic was. We have clinicians working there and provide their feedback. What have they learned? And so as a larger group, we were able to take all of this real-time information and feed it out to all of our practitioners. And so all of our practitioners have access to something called Zenith, which is our communication tool. Every clinician, every staff member has access to this. We dedicated certain pages for exactly what the stressor was at that time. So in the beginning of the pandemic, it was really about what is COVID, how do we protect ourselves, where is PPE? And so we had different pages you can see in this slide. We had different pages where we had all of our different divisions. We had a home page that provides exactly what the provider needed at that time. So if they needed more education about COVID that's up to date, it was literally updated every single week, again, with a group of clinicians coming together about best practices. So we gave education. As we move forward to throughout the pandemic, same thing as Dr. Barlow and Dr. Morris was talking about, volumes went down, then volumes came back up. And so I think really not only burnout, but I think we're really at fatigue now. In the beginning, it was certainly stressors over what is this, how do we protect ourselves, am I gonna have a job? Now it's been so percolated into not only our work, but our life. Really, I think we're seeing a lot of COVID fatigue. This page in itself is really our resource about COVID and its fatigue. There's regular messages that you can see that clinicians can listen to at any time about physician well-being. On the right, things that we may not always want to talk about or feel comfortable talking about. There's finances. A lot of clinicians may have been furloughed. There may be issues with finances that they may need questions to. Stress relief, and you can see on the right-hand side there, there's all these resources available. So we were lucky as a larger group that we have these resources that literally clinicians can either call, they can look on their computer, it's actually on an app they can look through also. We also did callbacks, and so we actually had a group within the company that actually called as many of the physicians and clinicians that we have, literally just as a checkup. It could be 20 to 30 seconds, and I can tell you most providers really found that of great value and thought it was just really a nice personal touch. If you move to the next slides. We also know that as a big group, there's a lot of things we can do for a large amount, but even in the centers itself, again, matching those stressors. So PPE was certainly one that I think all of us faced. And so we need to really celebrate, even at the local level, small things. So exactly Dr. Barlow mentioned, people were celebrating when we had, macros created on our EMR just to make it that much easier for the clinician to practice and see patients. Certainly here celebrating the arrival of PPE. If you want to go to the next slide. Speaking more of celebration, this is one of our PAs that actually volunteered her time in New York City, where the pandemic, really the epicenter was. When she was done with that, she actually did a bike ride across the nation from coast to coast, and it made local as well as national news. So we certainly want to celebrate these things. We wanted to celebrate as many good things as we could, and we collected stories through our communication platform and really fed that out to our clinicians. You go to the next slide. And certainly recognition, I'm sure this is something that everybody's familiar with. A lot of organizations were doing this, and we created these also for employees so that they can bring home, so we can put around our facilities just as a thank you, as a recognition. So, these small things, again, anticipating what the stressors are, and it could be different for different people. Finance, it could be PPE, it could be about benefits, what have you. So matching what the stressors could be and solutions that we can have kind of on a macro level, but also at the local level. Small things like this, recognition, giving them a token of recognition. It could be, food is a very common one also, making things easy, with your EMR. These small things add up. So, in our company, we really try to focus on, the overall clinician, not just one aspect of it, but we try to focus on all and really tailor it to the individual. So these are some of the things that we've done, we'll continue to do. We do anticipate COVID and, fatigue to actually start ramping up again as the flu season comes. So these are all things that we will continue working on. That's it, Laura. Thank you.
Thank you, Dr. Chow. I appreciate that. Unfortunately, Dr. DiBenedetto was unable to be with us today due to some technical issues. We hope they're not related to Hurricane Sally off of the Gulf Coast there. Dr. DiBenedetto's in Baton Rouge, so we'll go to Dr. Hicks out in California with your own set of environmental challenges.
Thanks, Laurel. So I am at the other end of the spectrum as far as, Dr. Barlow and Dr. Chow, representing large practices with lots of corporate resources and that kind of robust depth. I have a single clinic. We're located in Grass Valley, California. That's in the foothills of the Sierra Nevada, midway between Sacramento and Lake Tahoe. We decided, or I decided at the beginning, to be really involved with COVID because we've been in operation for about 20 years and we've become an essential part of the healthcare landscape here. And I just felt that this is something that we needed to do. So I've consciously taken a somewhat high profile in the community since the pandemic started. I've written columns in the local paper. We've organized weekly calls with community physicians. So every Friday morning, there's all the community physicians that want to, plus the hospital CEO. We have a call and just sort of check in with each other, which I think helps address the thing that Dr. Morris said about people, never seeing their colleagues anymore. That definitely helps with that. And then I'm on another call, a weekly call with the elected officials in the county from the towns and cities and the county elected officials and CEOs, including the hospital CEOs. And there's an FQHC here and Indian Health Clinic. So there's communication that way. And then the county asked me to produce a video on mask wearing, so we did that. And then some other, I'm the featured person in that, if you can believe it. And then there's other community leaders that have tagged on at the end. So I think by doing that, it gives the employees a sense that, well, let me say also, we're for the communication part, we have, since March, we've had huddles with the staff before we start. It used to be every day, now we've cut back to every week. And the reason we did that was because there were so many changes in our workflow that we just had to stay on top of it and communicate to everybody what we're doing. So I think the combination of what I've done in the community and then the communication with the staff has given our staff, both our clinicians and our back office and front office staff, a sense that they're part of something bigger, that they're really part of a, they're helping with a key part of our community response to COVID, and that they're providing a vital service to the community. So I think that definitely helps with staff morale. Another thing that we're doing is, as Dr. Barlow mentioned and Dr. Chow, we're also bringing in food for employees, bagels in the morning or lunches. I love the idea of having catered meals delivered at the end of the day after a long shift. So I'm going to look into that. That's great. Thank you, Dr. Morris. We've tried to give people a great deal of scheduling flexibility to help give them a sense of some control over their lives, because some things you can't control, like COVID. I mean, we can protect against it, but I think the scheduling flexibility helps. We've had a couple of staff members that and just did not feel comfortable coming into work at the beginning, so we were fine with that, and we made arrangements with them. We've also given all our staff, clinicians and everybody, Amazon gift cards. Those work better than bonuses because there's no payroll taxes or withholdings if it's under $500. So I think that was appreciated. And then I agree with Dr. Chow about COVID fatigue. We have had that, and it's compounded by, we're in the foothills, as I said, of the Sierra. So we live in forests, and there's forests all around us. And as you have probably heard, we're facing fires throughout the West and smoke and air quality. So it gives, you know, when I was telling my staff I was doing this webinar on preventing burnout, well, it gives preventing burnout an additional meaning where I live. In addition to the smoke, our clinic was under emergency evacuation alert for several days, 2 weeks ago. We've had what our Pacific Gas and Electric calls public safety power shutdowns, which is because so many of the fires in California were caused by deferred maintenance on the power lines, and then wind comes up, and so down power lines cause forest fires, and they've been sued into bankruptcy, actually. Because of that, now they have what they call public safety power shutdowns, where they turn off the power, and that happened last week, Monday night. The power came back on during the night Wednesday. When the power goes out, Comcast does not have generators for its facilities, so we lose internet, and our phones are internet based through Comcast at the clinic, so we lost internet and phone. We were on a microgrid generator from along with the hospital, so we had power throughout most of that, but no internet or phone, so that makes it hard too. So, you know, we are definitely feeling that burnout, or not that burnout, but that fatigue. Another thing that we've done, though, is during this whole thing, we support we support our staff, our clinicians, and during this, in the past few weeks, one of our staff members' house burned down. She was able to get out wearing a nightgown with her 2 kids and her dog. Oddly enough, this had nothing to do with forest fires, but the staff rallied around her, you know, put together a sort of like a kitty, and got her and her kids clothes and her a cell phone and iPads for the kids, and we found her a place to live right away. So I think that kind of mutual support for our staff and our clinicians also help. So that's what that's some of the things that we're doing, and I will definitely take some ideas from my colleagues here on this panel and try and do more.
Thank you, Dr. Hicks. I really appreciate that. Dr. DiBenedetto, I know he's tried to call in, or at least he's listening in. I don't know if he can speak, if we can hear him, Callie. Doesn't sound like it. So I think then, regrettably, but we will move then to any questions out there. We did have some questions that were sent in actually before the call, if we don't have any out there, but I'm going to turn it over. I don't know if Dr. McNeely, are you back? Then I shall turn it over to Dr. Toscano, if maybe you can help field some of the questions.
Sure, it'd be my pleasure to ask the panelists whatever comes up.
Sure. We did have one that was sent in advance. It says, urgent care has historically measured patient satisfaction Are there measures we should be instituting for signs of provider burnout and stress? That just like you look at a normal dashboard, are there things we should be looking at in our providers?
Ben, you want to take a crack at that one?
Sure. I think that it's educating the staff and the leaders in the clinic to watch for changes in the providers. And so what I've talked about with some of my directors and some of my center administrators are, if all of a sudden a provider's turnaround time is increasing, if all of a sudden there's a change in his satisfaction score, or there's something that has happened, you know, it's not a moment to jump all over the provider. It's a time to ask why. And sometimes those are signs that something's going on with the provider, that there's some burnout. And so I think it's just the typical stats that we keep. It's just seeing a drastic change all of a sudden when our providers.
If I can add to that, Joe.
Please.
It's, you know, it's hard to have a dashboard on burnout because, as I indicated earlier, you know, it's sometimes very non-specific. It's really hard to recognize, especially when you're standing back and you're viewing it from a distance. One of the strategies that we've seen work really well, it's one of our 3 core approaches to creating resilience in times of high stress, is a practice we call rounding. You may have heard of that. It's where leaders round on those direct reports, and it's truly rounding, just like we do on patients. It's you have a short conversation, check in with them, and sometimes when you do those kind of things, just as we do with patients, you don't need a 3-hour visit to kind of assess things. But we have prepared questions, and based on what we're rounding for, and I call this rounding for wellness, it's an evidence-based tactic that helps engage with the employees and does help the people that report to you open up. And simple questions like, how are you taking care of yourself? Or what one thing have you done for yourself to help your own wellness in the last 24 hours? When was the last time you took a break? When was the last time you were able to eat? I think one of the most important things is for us to realize that when we are providers at the front line, we tend to ignore our own well-being, and we do so to great harm, not just to ourselves, but also to the patients. And so it's just like when you're on the airline and they tell you when the oxygen masks come on, put your own mask on first, or if you're building a skyscraper, you've got to have a strong foundation. We have to take care of ourselves if we want to be able to take care of others. And if we don't take care of ourselves, we will not be effective that way. And so rounding, having short conversations with people, the huddle that some of the panelists have mentioned, I think those kind of things make such a big difference of pulling people together and beginning to recognize on a one-on-one immediate interaction how people are dealing and handling with things, which you just won't get, and it won't be reported on a dashboard anyway.
Yeah, Joe, this is Joe Chow. I'm going to dovetail onto what Dr. Morris said about rounding. That is something that we do also. I will say some of that, again, depends in varying degrees, but in general, it's a touch base. And we've primarily used that as a retention tool, but certainly as a marker for burnout, I think is important also. I'll give a quick story. The very first time, this is many years ago, so pre-COVID, the very first time that I did a rounding on one of our clinicians, again, I thought this perhaps may have been a 5 to 10 minute rounding to see how they were doing. Most of the times people are doing okay, they'll let you know. This one, as I shouted around and talked about what's been going on, this provider actually told me that she was getting sued at a different practice, and that's the first time she's ever been sued. That turned into literally a 45-minute to 60-minute discussion, which was completely worth it because, I would understand, to Dr. Barlow's point, if her metrics did start to go off, I'll catch it down the road. But in this fashion, it's something that she felt compelled that she wanted to let me know because she hadn't been through it before. So these little check-ins from rounding can reveal a lot of things and potentially can prevent issues when your metrics do start to go off. So it is work trying to get people to do it every single month, because I get everybody is very busy, but we typically task our medical directors or our lead APCs to do that. We've even had spreadsheets where we have people's names, and if you don't do it every month, try to do it every other month, and even just for your head, check, at least as a reminder for yourself to do it. So I agree. What started off as retention strategy can be used also for, again, a burnout indicator.
Yeah, I think a lot of that speaks to the relationships that we have. Dr. Morris talked about that as a kind of an intervention, the R in the ear mnemonic, but that's also how we know what's going on with other people, deterioration in function, and maybe reflected in metrics, but just talking to people or in your interactions with them, noticing that they're more irritable than usual, or they appear tired, or there are a number of personal things I think that come with touching base with folks, whether you call that rounding if you're not around them regularly, or somebody like Roger who probably sees all his staff members every day, noticing things like that. Those are great pointers. I have a question. This is actually pretty interesting. There seems to be an increase in the number of providers making public comments on Facebook, et cetera, about their stress and feeling like they have to work when they're having difficulties. How would Dr. Morris recommend employers deal with this kind of commentary or lashing out?
So, it's an interesting challenge. I think, as it's noted, citing the organization's social media policy is probably not the most sensitive way. However, you can't ignore it if that is the policy. But I think there's a more basic question that it always precipitates when you see this, is why are people going onto social media? Why are people going onto Facebook and blasting out their complaints? And there's truly, most of the time, there's only one reason, and that is they've tried internally and they haven't felt that they were heard. And so I do think that while the social media policy is important, we have to deal with it. We can't let people just go out and blast and have all their frustrations vented out in the social media, because that's not good for the organization. And most of the time they will tend to regret it afterwards. But I do think, again, if we take a step back and think why they're doing it, what they're complaining about their stress, what could we do to eliminate that stress? And a good number of our panelists have already talked about transparent communication. During times of high stress, we tend to be busy and busier than before in many ways, and yet we have a need for increased visibility, increased communication, increased touch points and connect points, increased appreciation, and of course, increase in the ability to take issues that could be problematic and solve them at the front end. I think it was Dr. Chow mentioned about flexibility, but truly, sometimes that's what it is. If you've got a work level, if you've got a schedule, if you've got kid responsibilities because they don't have school, don't have daycare, having some ability to be flexible. I was talking to an organization yesterday where two of the providers wanted to stay on telehealth because they didn't have childcare. And so instead of them saying, no, you can't do that, everybody's going to come in a certain number of hours, they got all the providers together and they worked out. Some of them have a lot of flexibility, and so they offset some of the telehealth to other people, and they saw more patients in the clinic and so on and so forth. They found solutions. I think that if they are going on the social media and they're spouting off, it's not good for the organization, and we have to address it from the policy point of view, but that's not the basis. And it's one of those difficult conversations that truly is an art. We say, talk about the behavior, talk about the impact of the behavior, and talk about what you need them to do and get a commitment for it. So, it might be, I know you're frustrated, but when you go on social media and you post all these things about team health or about UberDocs or whatever it is, you are putting it out there that you're not happy with the organization that you work for, and that undermines the organization plus the public's trust in that organization. if that's the impact you're trying to achieve, you're going to do a good job at it. But if you truly want to find a solution, then we need to sit down and talk about it and resolve it. But we do have to be open to the input. And if we're closed to the input, people will get frustrated and they'll vent on social media.
Yeah. Joe or Ben, being managers and directors of many, many providers, do you guys have any examples of people reacting on social media that you've had to deal with? Or have you been lucky?
I'll start. So from internal, so I'm sure a lot of us have had those complaints where, let's say, patients will say, I'm waiting in the room, the staff is talking, doing nothing, right? And we know that in most cases, the staff is doing something. They're likely grabbing something, labs or something like that, but they're overhearing. So we'll still get that on social media. And I use that as an example. So when patients complain from within, I think, as Dr. Morris mentioned, transparency of what the group is doing to address that. And so I showed you a picture of the people holding a PPE. They were very happy. 1 week ago, they could have been on social media saying we have no PPE, but they may not have understood. I just paid 3 times the amount of money to get that PPE sourced from China that got sent to, my corporate office in Knoxville, FedExed overnight to get it to us. So I think if we remain transparent and just say, hey, where's my PPE? This is what we're doing. We are actually paying more. We're trying to get it from this place. Someone actually from our group is driving there to get it, to come, to ship. To let them know that, hey, it is being addressed. If you don't see it right now, these are some of the reasons. And so I think being, transparent to say, hey, maybe there just is no PPE right now, or there will be in 1 week, and this is what we have to do. I think that helps people understand more before they say, again, that patient example, you're not doing anything. Well, you don't know that we're not doing anything. There's probably a lot of activity going on that you're not seeing. So if people are seeing that these are efforts that are being done, and as it pertains to, again, PPE, I think that's pretty commonplace that PPE was pretty much in low demand, during COVID. So it is hard for people to get, but just knowing these are some of the steps that we're willing to take to get it, I think would help, and hopefully, again, preventing that from happening.
Yeah, I think I'll just echo what what he said there. I got chills because I feel like he just read one of my emails about PPE and the 3 times the cost and what we were doing to deal with it. So, that's been a common thing lately about, what we've been hearing on social media is the PPE, and what he said is how we addressed it in our organization also. It's communication and telling them what's going on and what we're doing to address those issues.
Great. I have another question from a participant. Most urgent care centers work their providers for long shifts, 12 plus hours sometimes. Has anyone ever tested shorter shifts, job sharing as a solution? And if so, what were the results? I think Dr. Morris talked a little bit about this in terms of accommodating a particular desire of somebody to do telemedicine. And I guess it's sort of intuitive as a human being that the longer you're working, the more you're going to be maybe worn out and not burnout. But does anybody have any experience with that, working shorter shifts and producing better results?
Yeah, Joe, this is Joe Chow. So we look at this as a potential win-win scenario. So we have not only full-time practitioners, but we also have per diem. And so some of the per diem clinicians that we use have, we'll call them, day jobs in the community where they can't work, after hours or during hours, but they can work after hours as well as weekends. And so we do hire some of these per diem providers that can say, yes, I'll fill weekends, I'll fill, evenings. And I will tell you from a satisfaction standpoint, it only takes one time that you're able to split that shift so your full-timer can make their kid's soccer game, they'll remember that forever. So that even if it's that one time or two, if you can get that evening shift or that Saturday so they can attend their birthday that just kind of came up, that'll speak volumes. And again, for the per diems, for much of them, it works out for them too, right? They're looking for maybe some additional hours that they can't do during the week. So we try to make it a win-win, but I can say if you're able to do that, your full-timers that, work those long hours, especially if they have some kind of event that's really meaningful to them and you can get them that, it's very impactful.
Yeah, I would think this would be individual. I mean, there are people who like to work long shifts and fewer days. Some people like to work shorter shifts, and it's probably the case that making somebody do something that doesn't work for them is worse than whatever the thing is itself, a long shift versus a short shift, I would think. Hey, we got news that Dr. Benedetto is linked in now. He was going to explain some of the strategies that they've used to reduce burnout in their organization. So why don't we bring him online now?
Hey guys, can you guys hear me?
Yes, we can.
Okay, good. Sorry about that. I'm not sure what happened. Where I could hear the whole thing, but I couldn't get on, and I was muted. But anyway, I'll make mine very quick because I have some of the same ideas and sentiments of my colleagues. I'm with medical director with Premier Health, and we have almost 70 clinics in probably 6 or 7 states. But in Louisiana, where we're based, we were hit very hard early, so we had quite a bit of experience. I found that the biggest stress components to me were confusion and uncertainty. Some of the uncertainty was whether people were going to have a job because business got so slow, or they're going to keep their benefits. What we did is we limited everybody's hours to 30 hours a week so they could keep their benefits. Our goal was not to lose any full-time employees, which we were able to do that. Even our administrative staff took a 15% pay cut. That is the way we made our clinics viable to get through this COVID. Since then, we've gotten back to our normal flow. We also cut our hours in our clinics back. So that goes along with what you guys were talking about with the number of hours. We normally have 12-hour shifts. Some of our clinics went down to 8-hour shifts, so that helped a lot with the stress also. But that reassurance of having a job and keeping our full-time people employed and benefits aided a lot with the stress. The other thing was the confusion. I think COVID just almost created a mass confusion, and I think that was probably the biggest stress factor, and then an eventual some burnout factors. So I think the best way to deal with that, and what we did, was to have very clear guidelines on how to deal with the COVID patients. So clear guidelines regarding PPE, clear guidelines with patient flow, whether we had testing centers, which we initially had all outdoor testing centers. Then we advanced to curbside testing at our clinics, and finally in-clinic testing. But we had it very well thought out, and we did it the same in every single clinic so that every provider knew it was being done the same way at our clinics. We had telemedicine. We had been doing telemedicine for a year and a half, more as an offloading, but at least we're experienced in it, so we were able to jump on the telemedicine program fairly quickly. And then also we had things in place for treatment of non-COVID patients. All the patients were triaged in their cars. This helped with both patient anxiety and employee anxiety. We did some things to the EMR to help with the speed the process up, help with efficiency, such as built-in discharge instructions, built-in history of present illness with COVID exposures and things like that. One of the biggest stress factors I found, and I still work in the clinic so I can attest to it, was testing patients. Patients began getting very hostile and angry when you could not test them. We were able to get the Abbott ID Now test fairly early because Louisiana was hit so hard, and I think April 4th we started using it. However, we had a very limited supply. So patients were coming in and all demanding to be tested. Some met criteria, some did not. We made sure that we constantly updated our criteria, tried to make sure every provider followed the same criteria to help with the stress part of it. That way they could always tell the patient, hey, this is the company's criteria. They're following CDC guidelines. This is the way it should be, and there's a reason for it. And I think that helped quite a bit with the stress part of it, knowing that we were there and we were backing them up and we made changes constantly. As you all well know, some of this COVID stuff was changing almost daily, certainly weekly. And so just trying to be very, very consistent with the patients. Now that we have more tests, that part of it is better. Back to work instructions were very important, making sure all of our providers we're up to date on how to get patients back to work, what instructions, when they can go back. So I think that relieves a lot of the anxiety and stress with our providers, having all these things in place. We stayed in constant touch. We had a lot of Zoom meetings. We sent out a lot of emails. We remained very visible. We supplied lunches. All those things helped quite a bit in dealing with this. And I think I can agree with my colleagues that now it's kind of more of a fatigue thing than a stress thing. Now everybody's kind of in the routine. And I think when the flu season hits, we may be having this same conversation again. But that's about the things that we did, and I tried to keep it pretty short. So thank you.
Thank you.
No, that's great.
Yeah.
Kevin, thank you.
I think it's 2 o'clock Central Time right now, so I really appreciate everyone, our panelists, Dr. Morris, Dr. Toscano for taking over. I see Dr. McNeely is back, so thank you at least for teeing this up for us. But it does conclude today's town hall on urgent care implications of stress and burnout within the facilities. I want to, again, as I said, thank our panelists, our facilitator, and always our attendees. Our next town hall will take place at 1 p.m. Central Time on October 20th. We've had requests to address the increase in domestic violence. This is another unfortunate issue related to stress during the pandemic and people being more at home, losing jobs and all of the ramifications associated with that. We intend to address this disturbing trend from the urgent care lens. What does this mean in the urgent care facility itself? Thank you again for attending, for all you are doing right now, for what you continue to do and what you'll do in the coming months. We hope to see you back here on October 20th. Have a wonderful remainder of your day.
Take care, everyone.